Започваме последната част от нашето събитие. За тези от вас, които са от България, извинявам се много, преминавам отново на английски заради международния характер на събитието. Good afternoon, everybody. We are all ready to start the last session of this meeting for Sofia Echo Days 2021. The topic that we will discuss in this last part will be very interesting, and I would like to invite Professor Yan Ho. She will present the morphology of the univentricular heart.
For this session, I'm going to look at the morphology of hearts with functionally single ventricle physiology. And as we can imagine, it can encompass a whole lot of entities. So we start off with hearts with solitary and indeterminate ventricle. This is a true single ventricle situation. Majority of hearts would have unbalanced ventricular mass, that is to say, one big plus one small ventricle. So we start off with what we mean by univentricular atrioventricular connections and what we mean by solitary and indeterminate ventricle. So this is a chart that I use to describe univentricular atrioventricular connections. It can exist with any of the four variants of atrial arrangement. But importantly, at the atrioventricular level, there is only one ventricle that is primarily connecting with the atrial chambers. So univentricular atrioventricular connections. And these are the three variants in univentricular atrioventricular connections, absent of the right connection, that is to say the right side of the atrium. There's nowhere to go but to go through the atrial septum into the left side of the atrium and down to the ventricle. And the reverse situation here, absence of the left atrioventricular connection, left side of the atrium is blind, so all the flow goes through the atrial septum into the ventricle. Then in the middle here, situation of double inlet connection, whereby both atrial chambers drain or open into the main ventricle. Now, in terms of ventricular morphology, there are three variants. Middle here, a solitary and indeterminate ventricle. That is to say, there's only one ventricle in the ventricular mass. And this is by far the rarest. So we're going to start with looking at double inlet connection to the dominant left ventricle with the rudimentary right ventricle, which is the most common situation. And then look at this situation where there's double inlet to a dominant right ventricle with a rudimentary left ventricle. So you will note that we had in these two entities one main ventricle and the other a much smaller ventricle, usually much smaller ventricle, sometimes termed a rudimentary ventricle, meaning that it has no inlet component to it. So we start off with hearts with unbalanced ventricular mass, those with univentricular atrioventricular connections, a double inlet to a dominant left ventricle with rudimentary right. You see here the front of the heart, a rudimentary right ventricle, no inlet component, a ventricular septal defect there. And here, looking into the dominant left ventricle, we happen to see two atrioventricular valves draining the atrial chambers into one big ventricle. And over here, ventricular septal defect feeding into the rudimentary right ventricle, anteriorly situated. And we're just about to see an outflow valve here, semilunar valve, aortic or pulmonary. In terms of the valve guarding that atrioventricular junction, we see two separate atrioventricular valves, as we saw in that heart just now. Or you may have a common atrioventricular valve draining both atrial chambers, in this case, a heart with right isomerism of the atrial appendages. A left ventricle, morphological left ventricle with fine apical trabeculations. And less commonly, double inlet, again, left side, right side and left sided atrioventricular valves coming into a dominant ventricle with very heavy trabeculations. So right ventricle and two outlets coming from this right ventricle, turning the heart to the back, to the diaphragmatic aspect and left aspect. We see a small left ventricle receiving part of that left-sided atrioventricular valve. So there was some straddling of valve apparatus into this rudimentary left ventricle. Now, moving to absence of the right atrioventricular connection, then we see a small right ventricle, and we haven't opened it up yet. We see very deep ingress. This is the underside floor of that atrial chamber. Here we've opened up the right atrium, it's muscular floor, no remnant or evidence of a valve at all, so absence of the right atrioventricular connection. And turning the heart around, here's the front of it. We see this rudimentary right ventricle with ventricular septal defect connecting or communicating with a dominant left ventricle, which is here, a big left ventricular chamber. So this situation of absence of the right atrioventricular connection, the left-sided atrium opening to a dominant left ventricle, small right ventricle, and this is to be distinguished from those hearts with an imperfect valve, where there's a biventricular atrioventricular connection instead of univentricular atrioventricular connection. So its counterpart then, absence of the left-sided atrioventricular connection, which is this picture here. The left-sided atrium has nowhere to go but to go to the next door atrium down to the ventricle. So absence of the valve versus an imperfect valve. But we're going to look at this entity first. So here we are, a very narrow ascending aorta, aortic atresia, pulmonary trunk quite big ductus here, turning around to the left side, left atrial chamber, left atrial appendage, blind ending, left atrial chamber. The longitudinal cut through shows dominance of the right side of the heart, ventricular septum here, a slit-like left ventricle, just about pick it up. And here we have the floor, the sulcus tissue plane, bright echogenic tissue, showing you this wedge of sulcus tissue, epicardial fat forming wedge underneath the floor, the muscular floor of the left atrium. Absence of the left atrioventricular connection. So we have univentricular hearts, so-called univentricular hearts, but actually most of them primarily have one big ventricle plus one smaller ventricle. So how do you distinguish between one with a dominant left ventricle from one with a dominant morphologic right ventricle? Well, by taking a cross-section, short axis section through the ventricular mass, you will find that the ones with a dominant left ventricle would have a small chamber sitting more anterior superiorly, and this would be the rudimentary right ventricle, whereas those with a dominant morphologic right ventricle would have a slit-like or smaller rudimentary ventricle sitting at the back or inferiorly to the dominant ventricle. And just some examples then, with hearts with intact ventricular septum, critical stenosis, or atresia of the outflow tract, also giving a situation of one big and one small ventricle. So for example, with pulmonary atresia with intact ventricular septum, you may have this kind of situation, and hardly any patency in the pulmonary trunk. Here looking up into the right ventricle, very, very tiny, some sinusoids here, small tricuspid valve. And this cross-section shows you on the left side, a small left ventricular chamber, opening it up. You see this thick endocardial fibroelastotic lining a kind of walnut-shaped left ventricle, tiny, tiny little mitral valve just appearing here. Miniature mitral valve. There's no outlet at all. In this case, we have of the right ventricle forming the cardiac apex, small left ventricle gain, almost a tragic aortic outflow tract gain, very small mitral valve. So the option for this would be starting off with the kind of Norwood procedure and then progressing on to the Fontan procedure, univentricular repair. So to summarize then, the truly univentricular heart with a solitary ventricle is quite rare. Most of these hearts would have one big and one small ventricle. And the thing we would like to do is to distinguish between those that have two atrioventricular connections, a biventricular connection, versus those with a univentricular connection, as depicted on these little pictograms down here at the bottom. So thank you very much again for your attention. I'll be happy to take questions.
Thank you, Professor Ho, for the brilliant presentation. It's really exciting to see that everything that you performed, even on the video, but I know that you're a very perfect morphologist. I propose it to make the short comment after the presentation of Katie West, and then we could continue with comments about the univentricular heart and Fontan repair before and after together. Okay?
Thank you.
Okay. And so the next presentation will be again from Miss Katie West. She will speak about echocardiography assessment and echo post-Fontan repair.
Well, everyone, you've had a fantastic overview of these univentricular hearts, and I'm sure you'll agree they're pretty complex. So I'm very briefly going to take you on a Cook's tour of how we can assess these using echocardiography in the adult patient. So despite all of the advances and the great things that have come out of tomographic imaging like MRI and CT scans, echo remains the cornerstone of the postoperative evaluation, mostly because it's accessible. It's easy to get an echo, more difficult to get the advanced imaging techniques. But it does come with challenges. In adult cardiology, we're very used to being told how to measure, when to measure, what part of the cardiac cycle, what is a normal reference range, what is a normal LV, what is a normal cardiac pressure. But all of that becomes very difficult in patients with a Fontan physiology. So I'm going to run through the big 5 essential echo factors. These are the things that I think are the most important concepts to get in the postoperative assessments. The first is ventricular function. We'll run through valvular function, assessment of the connections, we'll check that there's no obstruction, and we'll also take a look at the veins. Let's get going. So the assessment of ventricular function is really difficult in these patients because the geometry often defies all convention. Remember the other day I spoke about the Simpson's formula and the anatomical assumptions of that it's this prolate ellipse. Sometimes we don't have a ventricle that looks like a left ventricle. It might be a right ventricle, it might be double inlet. So we need to turn to strategies that are not based on geometric assumptions. So what about these technologies? We can use fractional area change, myocardial performance, or the SD ratio. So I'll just talk really briefly about the SD ratio. This is really an indicator of global myocardial performance, so to speak. It's taken through the tricuspid valve Doppler or the right AV valve Doppler, and it's a ratio of ejection or systole to filling time. So it's a systolic to diastolic ratio. And you see in this particular patient, there is a lot of TR duration and not much tricuspid valve filling. That is the problem here. So this patient's SD ratio is 2.2. It should be below 1. So this patient turned up to our outpatient department in atrial tachycardia, and you can see that there is very little time for filling, and look at the ejection fraction. They went off, they had a couple of ablations, a bit of heart failure therapy, and came back a few months later, and you can see instantly that their diastolic filling time has lengthened, and now that ventricle can actually work properly, maintain a forward stroke volume, the ejection fraction is significantly improved because the heart has time to fill. And so you see in these kinds of patients that no number is going to tell you, no ejection fraction is going to tell you if the patient's okay or not. It's the serial assessment that is important in these patients. And this patient is now doing significantly better. I just want to talk very briefly about the importance of good lung function in the Fontan, because in these patients, as we breathe air in, it's also creating this negative space to suck blood back from the cardiovascular system. And so when we do Doppler traces on the conduits, we do see this sharp rise in inspiration. Really, you see more flow, more venous return, and that's a really good sign for these patients. So don't be worried if you see this respiratory variation in your Fontan patient. Valvular function is really important in these patients because this single ventricle physiology is particularly sensitive to volume loading. So changes in regurgitation or obstruction or any kind of change in the heart can put these patients at risk of throwing out the whole Fontan balance. It's really a balance of all of these pressures. So even moderate MR, moderate regurgitation can cause that balance to be off. Assessment of the connections really requires a good detailed understanding of the 3D spatial relationships, particularly of the pulmonary artery, the SVC, and the right atrium. So here is a patient, we have a 4-chamber view. This patient has no mitral valve. This is an absent left AV valve, mitral atresia, and this is the conduit here. And as we angle anteriorly and superiorly, because we're going to the pulmonary arteries and their superior structures, we will define this pulmonary artery bifurcation. So I'll watch, keep your eye on the conduit here. It just develops really nicely into a bifurcation. You need to learn to look for these things and to be specifically hunting from them. They're not clearly defined structures that will just pop up onto the screen by chance, unfortunately. So we need a good knowledge of 3D spatial relationships, and we need to understand which connections have been made. There's a whole host of standard procedures, standard operation, but also very varied anatomy and very varied surgical technique. So we need to know whether to look for fenestrations or not. This is a patient who has atriopulmonary Fontan, a very large right atrium, and as we angle anteriorly, we can see the LV outflow tract, but actually the connection is really on view here. It's just we need to know what to look for, and these connections are often down in the far field. Same will happen with the Doppler. On our standard settings for the Doppler, even though we know that this is the connection here, we don't really see very much, but if we optimize our settings to detect for venous flow, remember this flow is really low, so we need to reduce that scale, and that will bring out the flow when you are specifically looking for it. So we can do the Doppler, and we can see in this patient she has very active atrial contribution with a real big atrial kick following the P wave. We can also use other views. So this is a subcostal view. Again, remembering that the right atrial appendage is a very anterior structure. We go to subcostal 4-chamber, angle up anterior. We see this blue flow. Now, blue flow is going away from the transducer. That means this blood is leaving the right atrium, and we have a nice Doppler trace there as well. These patients are at high risk of developing thrombus, and this patient, you can see the right atrium is very non-contractile. We have a situation where there's a lot of stasis and a nice thrombus demonstrated for you there. The lateral tunnel operation, whereas with the blood goes from the IVC directly to the pulmonary artery. So use the views that you're familiar with. You know how to get the IVC view from subcostal. So just look a little bit more superiorly, and we can see the connection there. And you'll see that this color flow with the Nyquist limit down very low, optimized for venous flow, shows that blood is heading up towards the pulmonary artery. And again, we can look at the Doppler profile. Now, with the Doppler profile, it's not very well defined. What we do want to see is pulsatile flow, like we see on the left. We see that flow returning to the baseline, and that tells us there's no obstruction. In the image on the right, there is a continuous pressure gradient, which suggests there is partial obstruction or something's not quite right with this particular conduit. We also need to assess for obstructions both outside the heart and inside the heart. So the extracardiac obstructions would be the coarctation, pulmonary venous stenosis, pulmonary artery stenosis, particularly in the branches. And we should also look for intracardiac obstructions, which might be things like valves or membranes, or we also need to understand the importance of ASDs and VSDs, which is particular to the type of anatomy. Assessment of the veins is really looking at the hepatic venous dilatation. That's a sign of Fontan failure. These patients will have distended bellies. You can see a whole lot of ascites there, very abnormal looking liver, very little collapse on the IVC, which is incredibly dilated. So this is really a very fast track tour. My big 5 tips are know and understand the original anatomy. You need to know if the holes, the ASDs and VSDs should be open or closed, if they're unimportant or if they're vital. Read the surgical notes. Make sure that the surgical notes are accessible to know how many and which connections have been made. I've shown you the AP Fontan, the lateral connection. There might be a Glenn connection. Sometimes there's a third connection. It depends on the anatomy and the surgeon. Serial evaluation is the best assessment. There is really no normal value for these patients. So it's the serial assessment and degree and change that makes these patients their own best control. Understand normal relationships to know how to find the connection. So know where to find pulmonary artery branches, know where to find the right atrial appendage on a transthoracic view. And last but not least, definitely know how to drive your echo machine. This venous flow is low and flow. You will have to work to find that your regular settings that you use in adult cardiology won't help you to find this flow on a Fontan patient. It's pretty tricky, but you can do it with a little bit of help and a little bit of experience and exposure to these kinds of patients. If you're really stuck, there is, just to help you even a little bit further, because I know I've run through this really quickly, here is the International Society for ACHD. There are some consensus recommendations with protocols and outlining all of the key views and images that are necessary when scanning these patients. Keep a copy of this in your lab. Thanks very much for joining me.
Thank you for the brilliant presentation again, Ms. Katie West. It's really difficult to understand the morphology and hemodynamics of the univentricular heart, even to analyze the systolic and diastolic function, because this is a very tricky moment. I would like to invite maybe Professor Ho and Professor Wiley to comment a little bit short about this situation. What is very important for us to know when we're analyzing this kind of patient.
Professor Ho, do you want to give a comment on anatomical consideration first? Or?
Up to you. You're the boss.
No, as Professor Hristoff said, it is very difficult because there is a lot of variations. The ventricular morphology differ from each patient. Very hard to find two exactly the same patient. And also the valve and connections all different. So clinically, they can be very well until they developed arrhythmias and they have some infection. I think after repair, after their childhood, when they come to adults especially, they tend to have problems, often triggered by onset of arrhythmia. The ventricular function is especially difficult to accurately assess them. So a lot of times clinician is eyeballing it. I agree, if you know your patient, especially you followed those patients for many, many years, you can tell the subtle changes by your eye, but by the measurement, doesn't matter, ejection fraction, area change, all these parameters sometimes is not that accurate. And the ventricular function changes, the subtle changes may not be the contributing factor directly for their clinical deterioration until they have a very obvious ventricular dysfunction. Maybe that that is the time I think it's linked with a clinical symptom. I would suggest, we should apply all these parameters we have. If it's morphological like a left ventricle, you can use EF. If morphological is a right ventricle, we do use a fraction area change. Ultimately, I think 3D possibly is much more helpful because you can measure the volumes, you can measure the EF, which seems correlate with the symptoms. And other advanced technique like a strain, it's more helpful in analyzing the asynchrony. But, we haven't used widely in our clinical practice. I don't know how to explain the asynchrony and the clinical outcome in this group of patients. I think in the future we should do some more multi-center, gather all these patients together. We should work out some better quantification method using echo. And also I think MRI is very helpful because they can really accurately measure the volume. If you're not sure a patient had a really symptomatic change you cannot explain by your echo finding, I think we should have a lower threshold to offer the alternative method. And finally, cardiac catheter. I think that is ultimate investigation because often it's diastolic dysfunction which contributing to the early clinical deterioration. So we should have a little bit lower threshold for giving a cardiac catheter to measure the ventricular diastolic pressure and atrial pressure, and also to check the connections patency. So that's my my thought on this subject. Professor Ho, what do you think?
I think the issue really is that there are so many variations. They all come under univentricular. I mean, for example, you have univentricular atrioventricular connections, and then you have those with two chambers where one chamber is just so tiny.
Yeah.
And apart from these variations on the ventricles, you have also variations on the outflow tracts, on the valves themselves, and so on and so forth. And the sort of arrangement of the great arteries and how they connect from the ventricles. So you are faced with really a myriad of malformations in this particular range, if you like, that come under the univentricular physiology group.
In addition, I think the failure in Fontan is often multi-organ failure due to high venous pressure. The ventricular dysfunction is a late complication. They have a chronic high venous pressure, so they will develop like a kidney dysfunction, like a liver cirrhosis. This, we see more and more in our patients. I think in our most recent the research meeting, they have organized a research on the Fontans. They have found from GSTT group, they find that the most correlated with outcome is exercise ability, exercise test. And hence, if we train our patients, I think a physical training is good. Keep fit can help them for their quality of life.
Okay, thank you, Professor Lee. Here's one question. I think it's related with the hypoplastic left ventricle. Not unfrequently, the gland flow is continuous on Doppler. Is this normal or suggestive for obstruction or stenosis?
The flow across the valve or across the Fontan?
Gland flow, I think it's from the gland
flow, yeah.
Yeah.
Gland flow should have a little bit of pulsatility. So if they don't reach the baseline, they usually suggestive or not partially obstructed. But sometimes you really have to look on the 2D as well. if they really patent, the continuous flow also reflecting the distally pulmonary vascular quality. If they is less expansitile, the vessel is rigid, they may not be very pulsatile. So we should combine 2D and the flow Doppler flow profile. Basically, we like a bit pulsatile flow. If it's continuous, and we need to check more on the 2D as well to see the patency and make sure the flow velocity are not too high. Actually, they cannot be very high because it's venous flow. So distally, they only have possibly 17 maximum millimeter mercury of pressure. So they cannot be more than 2 meters, really. If it's more, then there is something really wrong.
Okay. Maybe it's very high, it's maybe obstruction or stenosis somewhere.
Yeah.
Yeah. Okay, thank you. I don't see the other questions, but we could continue now again with Professor Ho. She will present the morphology and congenital heart disease with pulmonary hypertension.
Hello, everyone. Can you hear me? It's a real pleasure for me to be here, and I'd like to thank Associate Professor Krasmira for her very, very kind invitation to have Professor Lee and I join the meeting. I'm going to talk a bit about the association of congenital heart malformations, the types of congenital heart malformations with pulmonary hypertension. This is going to be a very short presentation because I think it's more important this talk that follows this. So to start with, there are several clinical pulmonary hypertension groups as listed here. So classification is quite complex. Can have pulmonary arterial hypertension or pulmonary hypertension due to left heart disease or due to lung disease or thromboembolic kind of event, and unclear multifactorial pulmonary hypertension. So I'm going to look first at this entity only, actually, the pulmonary arterial hypertension in association with congenital heart defects affecting up to 1/4 of the patients and 5 to 10% of adults with congenital heart patients. There are lots of variations in severity from mild to the Eisenmenger syndrome type of presentation. There are various classifications in this group of lesions. And you can see on this slide, which is very, very busy, in this particular type of classification talks about simple pre-tricuspid shunts, simple post-tricuspid shunts, combinations of the above, those complex congenital heart malformations, and various others. And then they also looked at lesion dimensions, sizes, small to moderate, or large, which are more than 2 centimeters diameter. The direction of shunt, predominantly systemic to pulmonary, or predominantly pulmonary to systemic, or even bidirectional. Then associated extracardiac abnormalities, and of course in the adult patients, not to repair the repairs, not to forget the repair status. But for the purpose of this talk, I will adopt this nice diagram from a very elegant review article published just a few years ago, talking about the basic characteristics of 4 clinical subgroups with pulmonary arterial hypertension. So we have the Eisenmengers, and then we have these various other categories coming into play. So to start with, clinical subgroup A, the Eisenmenger syndrome, with a reverse shunt, that's to say pulmonary to systemic, and they have chronic cyanosis. Over here, we have a picture of an Eisenmenger heart, which is actually taken from the museum, which you see sitting behind me. And this is exemplified in this instance by a very highly situated ventricular septal defect underneath the aortic valve, but no subpulmonary obstruction at all. so quite good outflow tract to the lungs. And indeed, when Eisenmenger described this kind of malformation, this combination of malformations, he alluded to the fact that it's a fellow without pulmonary stenosis, high ventricular septal defect, overridden by a rightward aorta with a normal or dilated pulmonary trunk. But since then, this term Eisenmenger has been adapted, and Paul Wood, previously a cardiologist based at the Royal Brompton Hospital, back in the 1950s, described pulmonary hypertension with a reverse central shunt and called it Eisenmenger's physiology. And this has further been enlarged and the eponym extended to the Eisenmenger complex and syndrome, cyanosis due to a reversed or right to left shunt. And this is an example from our museum showing a large mid-muscular ventricular septal defect in right ventricular view and a left ventricular view. Note the very, very thick walled right ventricle. And now subgroup B is pulmonary arterial hypertension with persistent systemic to pulmonary shunt, usually with a moderate to large non-restrictive defect. Here we see the front of the heart, the right ventricle, very, very thick walled, largish pulmonary trunk, and turning to the right atrial view, here we see an atrial septal defect or interatrial communication rather, sitting right underneath the opening of the superior cable vein or superior vena cava. So it is above the level of the intact atrial septum. In other words, defect is just above it and usually associated with partial anomalous pulmonary venous connection to the superior cable vein. Moving on to clinical subgroup C, then we have those associated with small or coincidental defects. For example, this heart here, right ventricle opened up. We see a very, very thick walled right ventricle, not something we expect to find in a 30-year-old. We see here coming up there as a slightly dilated pulmonary trunk, again, small ventricular septal defect. Another example, in this case, a patent ductus arteriosus or patent arterial duct. I call it a window duct because there's hardly any length to it at all. And here with the aortic arch coming down to the descending aorta. Again, you note kind of dilated pulmonary trunk and dilated left pulmonary artery. And this is another case, which is from a patient, again, with a patent arterial duct, but this is really quite not very good looking at all. We have a very, very dilated pulmonary trunk. You see the left pulmonary artery, calcified arterioma here, but it's the right pulmonary artery that was very, very impressive. 7.5 centimeter diameter filled with spherical aneurysm with thrombus. This is from a 55-year-old female with dilatation of proximal pulmonary arteries. Another examples, this group C with small coincidental defect. This was a patient, just guess the age.
Yeah.
Female, 83 years old, first diagnosed with atrial septal defect at the age of 63. Look at the size of that pulmonary trunk, really huge pulmonary trunk. And opening up here, right and left pulmonary arteries, very, very dilated. So the proximal pulmonary arteries seem to be affected. In subgroup D, then those who've had repairs of their septal defects, as in this one here, previous atrioventricular septal defect repaired in childhood. Then we see enormously dilated pulmonary trunk and dilated pulmonary arteries, and sort of kind of areas of arterioma as well. So I think the small pulmonary arteries, plexiform lesions and so on and so forth, but the larger pulmonary arteries tend to be ignored. And here we did a little study of a limited series of specimens looking at the architecture of the pulmonary arterial wall. And we found that they exist, and they are variously characterized as diffuse internal thickening, atypical elastic pattern, as you see here, the dark areas here, lots of significant fibrosis, the coloration in red, and cystic medial necrosis, these empty spaces that can contribute to wall weakness, dilatation, aneurysm, and in very, very serious cases, even rupture. And here we see a 29-year-old heart from a 29-year-old, again, with a very, very dilated pulmonary trunk. So Martina Prappa, who led on this paper, stated that the large pulmonary arteries matter too in these cases. So in summary then, it's important to know what you're facing with, as we can see that there's a very heterogeneous group of congenital heart defects that can come under this category. And it's really a matter of looking and sorting them out very, very carefully. And I would like to take the opportunity to say that Professor Lee and I and colleagues at Brompton are holding a meeting in September this year. Thank you very much.
Thank you, Professor Ho. Really interesting introduction for the this topic from the morphological view. I suggest we make the short comments after the presentation of Professor Lee, because she is actually on the echocardiography assessment of adult congenital heart disease with pulmonary hypertension, and then we could make another comments. Professor Lee.
Good afternoon. My talk is on echo assessment of patient with PAH associated with congenital heart disease. So according to these ESC guidelines, using echo to assess the probability of pulmonary hypertension, we can use the tricuspid valve regurgitation velocities. If the TR velocity is less than 2.8, and there is no additional sign of PH, the probability is very low. But when the TR velocity more than 2.9, with additional sign of pulmonary hypertension, then patient is more likely to have a PAH. The other signs, including looking at the RV, pulmonary artery, and the venous system. For the RV, we can look at the full chamber view. If the base level RV is more than LV, then that's suggesting RV dilatation. Or we can look on the short axis view. If the LV eccentric index more than 1.1, that's all suggestive, indirect sign of pulmonary hypertension. So from pulmonary artery Doppler, we can measure the acceleration time. If this time is less than 105 milliseconds, that's also suggestive increased PAP. And also we can measure the early diastolic pulmonary regurgitation velocity. This velocity more than 2.2 is indicative of PH. Also, you can measure the pulmonary artery diameter more than 25 millimeter, suggestive PA is dilated. Then we can look under the IVC, if the IVC is dilated and not collapsing. And also the right atrial dilated, the area more than 18 centimeters squared. That's all the indirect sign of PH. So combined with TR velocities, the probability of PH can be made. Here I'm just showing how simple to get the tricuspid valve regurgitation, then put in the Bernoulli equation, we can calculate the RVRA pressure gradient at right atrial pressure. We do get RV systolic pressure. This is very easy. I'm sure everybody knows how to use this. But bear in mind, when we use the TR, we have to know in the published data, the correlation between Doppler and the CAST measurement of RVSP varies a great deal. The correlation varies between 0.5 to 0.95. So you can see between this variation, we can easily underestimate PA systolic pressure. Here is a small study from Brompton many years ago. It indeed shows a correlation do exist between Doppler and Keth measurement of RV pressure. Nevertheless, Doppler is constantly underestimate RV pressure by about 30%, especially when there is a severe pulmonary hypertension, the pressure more than 90. Add right atrial pressure, this difference can be reduced. Nevertheless, still have about 20% underestimation in severe pulmonary hypertension. So in order to avoid underestimation, we have to make sure we need to add appropriate right atrial pressure when we are calculating the RV RA pressure gradient. So normally in severe pulmonary hypertension, we should add minimum of 15 millimeter mercury right atrial pressure on it. Then our underestimation should be avoided. The second parameter we can use to estimate mean PA pressure is the early diastolic PR flow velocities. You can see that this early PR regurgitation velocity corresponding to the dicrotic notch measured on cardiac catheter. So it's also at the time when the mean PA pressure was measured with cardiac catheter. From this study, you can see the correlation is very good, especially when added right atrial pressure. With our clinical experience using PR velocity estimated mean PA pressure is less likely to underestimate severity of the PA pulmonary hypertension. If we use the TR in a lot of patients, we do underestimate the severity. The third parameter you can use is the acceleration time measured from a pulmonary artery Doppler. So acceleration time less than 100 corresponding to the mean PAP about 25 millimeter mercury. And you can also put in this formula to calculate the mean PA pressure. Just remember, when patients have severe pulmonary disease, the lung disease, when the pulmonary resistance is increased, they also can have very short acceleration time, so they do not necessarily have increased pulmonary artery pressure. So we have to remember to differentiate them. So according to the guideline, congenital heart disease or associated with pulmonary hypertension has been categorized into these four major groups. First is Eisenmenger, which is also at the extreme end of the disease. We know in Eisenmenger with large left-right shunt, that patient develops severe pulmonary hypertension. The RV or PA pressure is at systemic level. The shunt reverses and clinically patient presented with cyanosis. Second group is left to right shunt, despite have severe pulmonary vascular hypertension. The patient still shunting left to right. Third group is PAH with coincidental congenital heart disease, usually with a small ASD or VSD on its own. It cannot explain the severity of PAH. So we think it's just coincidental findings. Fourth group is postoperative pulmonary arterial hypertension. When patient has congenital heart defect closed, the PA pressure not necessarily reduced, especially at the time of repair. There is already certain degree of pulmonary arterial hypertension. Second group in this category is the patient indeed have very low pulmonary artery pressure, but when they grown up or late in life, they will have severe pulmonary arterial hypertension. In one of the example is patient with transposition of great arteries. we have seen patients had the timely arterial switch operation or atrial switch operation. Then some years later, we find the patient have severe pulmonary arterial hypertension. The reason for it seems not fully understood. In our clinical practice, we also see patients with more complex lesions like pulmonary atresia with MAPCAS. They will have segmental or unilateral PAH. Then increased pulmonary vascular resistance in post-Fontan repair. Quite often we will put in a topic like this because any increase, minor increase in PA pressure has a significant hemodynamic consequence in Fontan circulation. The increased PA pressure due to past or present pulmonary venous hypertension will be a large group of our patients because most of the congenital patients will have a diastolic dysfunction, and sooner or later they will develop pulmonary arterial hypertension. So this congenital heart disease with associated pulmonary hypertension is indeed a very complex patient group. Paul Wood, he has worked in Brompton Hospital, has written a very important scientific document on pulmonary hypertension and Eisenmenger. According to his definition, Eisenmenger syndrome is pulmonary hypertension at or near systemic level with a reversed or bidirectional shunt between the pulmonary and systemic circulation, and the pulmonary vascular resistance is more than 10 Wood units. So the large left-right shunt develop into Eisenmenger syndrome. They can have established pulmonary vascular disease by the age of 2 to 4 years old. It's indeed very young. And accelerated onset has been seen in patients with Down syndrome and cyanotic heart disease. Sometimes they can, especially in Down syndrome patients, they kept their fetal circulation type and their pulmonary vascular resistance has never dropped. So right ventricle has been facing very high afterload just before birth and even after birth. So the median survival at the moment is between 40 to 45 years. Actually, we have already seen our patient live into 70s. With the advanced treatment, their survival definitely is improving. But general anesthesia, surgery, dehydration is poorly tolerated by Eisenmenger patients. Pregnancy carries 30 to 50% maternal mortality. Again, this mortality has been improving with the help of advanced treatment. Closure of the defect is detrimental once obstructive PAH has developed, but they all need careful management. If they have been looked after very well, they can survive and have very good quality of life. So what kind of congenital lesions have Eisenmenger syndrome? In these two big studies, you can see most common is ventricular septal defect, followed by the ductus and atrioventricular septal defect. We do see some number of patients with the atrial septal defect can develop severe pulmonary hypertension and Eisenmenger syndrome. They usually present later in life, usually after age of 40, then they normally have very, very large defect. So long-term volume overloading can lead to pulmonary hypertension, but it's only in small number of them. So echocardiographically, diagnosis of Eisenmenger syndrome maybe is not too difficult. Like this patient I'm showing you, if you find there is a large defect, atrial or ventricular septal defect with laminar flow bidirectional shunt across a ventricular septal defect, that's suggesting near equal LV-RV pressure. So in the absence of pulmonary stenosis, that's usually give you the diagnosis of Eisenmenger syndrome. But when we look at the patient of congenital heart disease with pulmonary hypertension compared with idiopathic or hereditary PAH, we find there are significant difference, especially in terms of survival. Even with the help of advanced treatment. This is a contemporary study from the REVEAL registry. You see, after 7 years, the difference between idiopathic and congenital group still exists. So with Eisenmenger and congenital patient had a better survival compared with idiopathic. The reason behind it is in a lot of patients with congenital heart disease, Eisenmenger syndrome, especially those post-tricuspid lesions like VSD, AVSD, we often find the right ventricle had 3 layers of myocardium, resembles that of LV, especially they have a clear medium circumferential layer of the muscle. This may help to maintain the right ventricular chamber size and keep good contractile function, and at the same time not increase in right atrial pressure. So clinically, they do much better. This has been proved by or has been studied using the speckle tracking in Eisenmenger patients. This is our study. Say in 83 Eisenmenger, we studied using the speckle tracking and compared with 40 other cause of PAH. We find in Eisenmenger syndrome, patients have better transverse strain. So this transverse strain must be the contribution from this circumferential layer of the myocardium. And among the Eisenmenger patients, we find post-tricuspid shunt, they have a better transverse strain than pre-tricuspid shunt, those especially the ASD. And this transverse strain is specific parameters can predict their survival probability. So with this strain, more than 22% had a much better survival compared with patients with less than 22%. So we see RV adaptation process depends on the time of onset of pressure overload and time course, of course, the degree of severity of the pulmonary artery hypertension. One of the examples I want to show you is compared with Eisenmenger VSD, who facing the high pressure very early in their life. We have the same patient with COVID. They may develop pulmonary hypertension later in life. That means when they are adult, and in a very short period of time, usually in a few weeks. This is one of our patients in his 40s. So give a very short history of disease, and you can see his RV is really suffered. With sudden onset severe pulmonary hypertension, RV cannot prepare itself to cope with the severe afterload increase. We see pulmonary hypertension can be a sequential of the events. The right ventricle, when they're facing the increase, the afterload, first they can develop the adaptive changes. That's by increase the myocardium, increase the contractility, which maintains the function and its size. But over the years, especially in congenital heart disease, this can be 30, 40, 50 years. The right ventricle finally will develop failure, will become dilated and dysfunctional. But with the advanced treatments, this process can be slowed, sometimes can be reversed. So it is important we can monitor this process very carefully and accurately in order to guide the medical therapy in our patients. So what parameter can we use? Here, we're just showing you TAPSE. It's still one of the commonly used parameter. There are several studies have been shown this parameter have its prognostic value. Here in our ICEMANG study, we find TAPSE more than 15 had a better survival and compared with patients with TAPSE less than 15. And if we put all the parameters reflecting the right ventricular dysfunction and increase the right atrial pressure in a composite score, the prognostic value become much more accurate. Here we have put right ventricular systolic diastolic ratio that is measured from pulmonary Doppler or from tricuspid valve inflow Doppler. The systolic duration is measured as tricuspid valve regurgitation duration, and the diastolic duration is a failing time. So in normal, usually diastolic period is nearly equal or even longer than systole. When there is an increased afterload, right ventricle cannot cope. This is why the systole prolonged, which as a consequence will shorten the diastole. So this also been called asynchronous right ventricular dysfunction. It is a form of severe RV dysfunction. So this ratio more than 1.5 and TAPSE less than 15, right atrial area more than 25 square centimeter, and right atrial and left atrial area ratio more than 1.5. If we put all those together, the accuracy in predicted prognosis is increased dramatically. On the ROC curve, you can see the area underneath the curve is 0.9. If we use TAPSE alone, the area is only 0.67. So more parameter we use, the more accurate we can predict the prognosis. So we all know development of severe tricuspid regurgitation usually is the sign of end-stage the pulmonary hypertension disease, but often tricuspid valve regurgitation give you a higher TAPSE and also fraction area change. That is because these parameters are volume sensitive. But here is elegant study using 3D. You see in patients with severe tricuspid valve regurgitation and pulmonary hypertension, the right ventricle lost its normal triangular shape. It became a cylinder type of the shape. This also means it's less efficient or effective in pumping the blood. Here the study also show a severe tricuspid valve regurgitation together with mean PAP more than 45 is carries very poor prognostic value. Patients have very lower survival probability. So in our big study in predictors of death in ICEMANG, we have found pericardial effusion is a sign of a poor prognosis. I think in this group, when they develop pericardial effusion, often means they developed right ventricular failure. But I have to point out, in a small group of patients, especially Down syndrome baby, they usually have benign large pericardial effusion with the AVSD and ICEMANG, but they can be clinically stable. So we must bear this in mind when we follow the patient to differentiate these two groups. So in summary, we see there is a striking difference in RV morphology and function between adults with ICEMANG syndrome and others with idiopathic PAH and hereditary PAH. Thickened right ventricular myocardium in ICEMANG with posterior tricuspid lesion may increase myocardium contractile force by intrinsic myocardium, therefore to maintain the myocardium function. The ventricular dysfunction raises the right atrial pressure and development of pericardial effusion are associated with poor prognosis in patients with Eisenmenger. So we must using our echo to monitor these patients very carefully in order to guide the right treatment for a patient. Thank you for your attention.
Professor Lee, for the very nice presentation. It was very clear, explained everything that we need to know about the pulmonary hypertension and those of kind of population. So I just want to ask you, at what time it's better to send the patient for the cardiac surgery, especially for the developing Eisenmenger syndrome? It's a very crucial topic because Eisenmenger is the last stage of developing the pulmonary hypertension.
Yeah, thank you for this very interesting question. You know, when they established as Eisenmenger syndrome, we think it is not wise to send patient for surgery. Although there is a publication suggestive you can use treatment, then after treatment, then you can close the defect. They haven't reported, actually I have seen the cases after treatment, the pulmonary vascular resistance seems to dropped a bit, but with the closure of the defect, the patient will not do as well as we left the defect alone. So for established pulmonary vascular disease with Eisenmenger syndrome, I think we always say closure of defect is contraindicated. Only the patient with severe pulmonary hypertension but still left the right shunt, if clinically still pink, we can consider closure, but has to be studied very carefully using cardiac catheter. I think at the moment the guideline said if the pulmonary vascular resistance is less than 4, then possibly we can consider to close. Between 4 to 8 is debatable. Maybe fenestrated closure is better, but above 8 still considered shouldn't close them. Actually, you know, when the patient have Eisenmenger or have left the right shunt, the prognosis may not as bad as the patient had severe pulmonary hypertension and defect being closed, because the two ventricles work together, they are better than the one right ventricle suffer from suprasystemic hypertension. Thank you.
If you allow me also to thank you very much for the nice presentation. I think that you're quite right that the closure of the defect is important, but we also have to consider that nowadays we have also medical treatment of those patients with pulmonary hypertension due to Eisenmenger syndrome, which at least improve the quality of life. And in my opinion, they also improve, they have also a very good prognostic effect in these patients with prolonging their lives with several years. So in cases with fixed pulmonary hypertension, we may consider, and it is a very good indication for such a medical treatment with medications that can reduce the pulmonary resistance. Thank you.
Excellent. That's quite true, really. I have one of our patients, she lived until 74 with a large VSD Eisenmenger, and she worked until the day, I think she left, as a professor of medical economics. It's wonderful. You look after them, they have very good quality of life. And using the medical treatment, I think it's definitely benefit for them. Thank you.
Yes, thank you, Professor Ioto, for your comments. I'm very happy that you joined our meeting. There is also one question. I think it's more pointed for the Professor Hall. could you comment the absence of the pulmonary artery branch maybe will be a reason for the pulmonary hypertension?
Yeah, you have been.
Sorry, I'm not sure I caught the question right.
The question is in the chat. Could you comment on the absence of the pulmonary artery branch as a reason for the pulmonary hypertension?
Well, in these cases, I mean, when you say absence of the right pulmonary artery, say one of the branch pulmonary arteries, it may be arising from the aorta directly. That would be my concern.
It's not absent, maybe.
Not absent, so, yeah.
It is the atresia of the pulmonary artery.
I think in the patient with pulmonary atresia, we see segmental pulmonary hypertension. We often think they have intrinsic pulmonary vascular abnormalities. The vessel itself are not normal. This is why they have high pressure in them. They're very rigid vessels. Thank you.
Thank you for the comments. Any comments, colleagues from our panelists?